Welcome to our PFCC Partners Community of Practice Workshop. I am Naomi Williams. I am the Patient Family Engagement Specialist and will be your host today. And my co-worker here, Noah, might be chiming in. Once Leslie starts talking, you won't hear him anymore. We are recording and we'll add this month's presentation to our PFCC Partners YouTube. If you have not already subscribed, I invite you to subscribe to our channel so you can stay in the know and hear past presentations and future ones in the event that you are unable to participate. If you are new to PFCC Partners, I know we have some veterans and we might have some new people as well. So just to give you an idea of what and who PFCC Partners is all about, you can see our mission, vision, and values. But what we are aiming for is we want to see a health system transformed into one that works with people and through communities as partners in their well-being. We want to be a catalyst system for improvements by centering that human experience of health. And we absolutely recognize the critical role community engagement must play for every effort at delivering health equity. So when we talk about healthcare, we know that the U.S. healthcare system is very complex. There are millions of people, hundreds of agencies and organizations. The complexity of this can make it difficult for people to access the care that is aligned with their needs, health, priorities, and preferences. PFCC Partners believes that a system that centers care and care processes on the person, the human, has the potential to reduce complexity and advance a culturally humble, equitable healthcare system. Oh, I'm being tech challenged this Friday. It's going backwards instead of forwards. So PFCC Partners recognizes the space and opens space for patients, family caregivers, and community voices to drive improvements in this complex system. We know that these voices are a huge catalyst for improvement and in the system's change. Our team has decades of passionate experience partnering with healthcare systems and leaders engaging in leaders. We are leaders in engaging those with lived experiences in their efforts to improve their care. We at PFCC Partners work to open spaces by creating partnerships that allow for improvement. One of the ways that we do this is through our PFA network. And Laura Jackson is our Director of Community Engagement. Through PFA Network, it's a patient family advisor, it's a community of patient family advisors for patient family advisors, where they come and use their lived experiences to improve healthcare, to influence healthcare improvement. So that's just a little bit about us. I invite you, if you're not familiar with our PFA network, if you've not visited that site, by all means to check us out. And I believe Lindsay can drop that link in the chat for us. So way where we're able to engage with their engagement opportunities, skill building, I can't talk today, skill building opportunities, as well as networking. So without further ado, let's get to this month's presentation, where we're looking at, and we have the pleasure of hearing from Leslie Martinez, who will be talking about how to build and sustain meaningful patient and family advisory councils. Let me just tell you a little bit about Leslie before I turn it over to her. Leslie is a certified professional in healthcare quality and has a doctorate in practice and master's in education degree. If I can ask everybody to mute for just a moment, please. Her experience leading up to becoming a quality improvement coach was in labor and delivery, ER trauma, and as a nursing instructor at the LA County College of Nursing as the OB content expert, teaching pediatrics, OB postpartum ambulatory care, and med-surg clinical, as well as high fidelity simulation along with theory across the curriculum. Leslie's passion is advocating for marginalized communities by outcome and access improvement through facilitating patient and family engagement. Her focus is providing an equitable patient and family voice on the current state of healthcare systems. Without further ado, I will pass it over to Leslie Martinez. Thank you.
Thank you, Naomi. I'm going to go ahead and share my screen if that's okay. Can you see my screen okay?
Yes.
Okay, it's in kind of that funky mode, but if you're okay with it, can you see it well enough?
Yep.
Okay.
I see it well. Yep.
Okay, thanks. All right. And please just let me know. So just so you know, anytime at all that you have a question, you really don't have to wait till the end. I really am happy to answer anything when it's something that you have a question about versus waiting till the end. So if there's something on a slide, maybe even an acronym or something that I forget, please let me know. So I'm more than happy to kind of go through anything like that at all. So please stop me at any time. I'm elated to be here. I can honestly say 4 years ago, we started our journey as a patient family advisory council. I had never heard of one. I didn't know what it was. So I don't know if you're kind of where I was in life, where I really had no idea what any of this stuff was, but this was really brand new for me. This was brand new for our team. And this was just something where our CEO came to me and just said, can you start a patient family advisory council? And I just said, sure. I have no idea what that is, but I will figure it out. And honestly, after 23 years of being an LA County nurse, this has been the best job I've ever had. And this isn't my whole job. This is about this big of my job, but it's the most meaningful part of my job. This is the one thing that still makes me feel like a nurse because I'm with patients all the time and we're a family and we're a bilingual family and we provide just a great storyboard and a safe space to talk and to really make things better for our organization. So it's really the sweetest part of my job I've ever had. And, if you've birthed babies, you'd think that would top that, but this is pretty darn cool. So I appreciate getting to talk about this with you today. Just to give you a tiny bit about myself, about, right before the pandemic, I was kind of throwing around the idea of different things and I was volunteering a lot for all my kids' stuff. So Girl Scout leader and team mom for baseball. And I taught the art program at their school. And then the pandemic hit. It was like, oh gosh, now I'm not a part of any of this stuff. And so I thought I'll go back for my doctorate and I'll do homeschool with them because they have to do homeschool. So I'll do that too. Yet somehow we were all on different screens, the same Wi-Fi and in different rooms. So it didn't really work out the way I thought, but what I got out of it was this meaningful project. I focused on how to achieve patient-family engagement through having a patient family advisory council. So after reading 400 articles, I really realized there's no way to measure a patient family advisory council's effectiveness. There are no tools out there. There's nothing that says if you achieve these metrics, you probably have really good patient family engagement. You're probably doing a pretty good job, So we created 4 tools and came up with a whole dashboard, and it's really been an exciting thing. So that's what I'm going to share at the conference in May. So if you're there, I'll be so happy to meet you and talk about those things and share out those tools that we've had pretty great success with and shared with other hospital systems too. But that's enough about me. Oh, goodness. Okay, so I'll have to learn how to use this little screen. If I push one time, it doesn't. Okay, let me figure this out. How do is that better? Is that okay? Okay. Oh gosh. There, that's what we'll do. So this session, what we're really going to talk about is the importance of patient-family engagement. Really, what does that mean? How do we achieve it? This doesn't matter whether you have a small ambulatory care clinic that's private. This doesn't matter if you have a healthcare system like ours, which is a public safety net hospital. Just in our facility alone, there are 10,000 employees. We have every service there is possible, anything from psych to specific hand surgery. I also went to school here, so I've been a big part of our organization for a long time, and finally having something where our patient's voice leads what we do at our healthcare center is so meaningful. So I'm so excited to share that. It'll also, I'm hoping what this will answer for everybody is really how and where do you begin? Because I really didn't know. I mean, again, this was just our CEO and our CQO saying, Leslie, we want you to do this. And I said, sure, and just kind of went for it. So I'm hoping that this will really help out with how and where to begin, and really how to use them, not just for feedback on what you're already doing, but really more of the engagement of they start the project with you. This isn't something where you say, hey, this is what we're doing. What do you think about it? This is really, we're thinking of starting a whole rehabilitation center for long-term care. We want to partner with you through co-design so we can actually create that together. I mean, it's incredible to me because think about how much you would maybe pay for these things, to have actual subject matter experts, which are our patients and our community, coming in and telling us all these things. And they do this out of the goodness of their heart because they want to be at our facility and make it better to give back, which is just remarkable to me. So this has been a really cool part of my job. The definitions that we're going to look at today is really person-centered care, which the World Health Organization defines that as really just someone being in charge of their own care, having that engagement over their own care. When we look at patient-family engagement, it's so much more than that. In the AHRQ, the Association of Healthcare for Research and Quality, really looks at that more as something of a responsibility of not just the patient, not just the community, not just the family member, the loved ones, but really we're also looking at what policies and procedures and what place does the organization have set up to where we can create this patient-family engagement. What gives them a voice? What platform do they have? Is it in their own language? Is it culturally responsible? Is it equitable? How do we get the word out there? Is it something everybody can hear about versus, only a specific community can hear about this, so we're only drawing in certain types of patients? This should really give an equitable seat at the table. And that's anywhere from the bedside all the way over to the boardroom, whether they're presenting at your execs table, which ours do, whether they're at the bedside with their patients, whether it is creating educational materials. I happen to be a quality improvement coach. So my whole life at work is data and analysis and process improvement. That's what I do for a living, even though I'm a nurse. So I live and breathe this every day. So a lot of our PFAC, because that's what I know, that's really kind of what I moved them into immediately. So our PFAC is really embedded in process improvement. And that's not how they all work. They can all be completely different. You can use them as wayfinders. You can use PFACs as, these patient-family managers can do anything. So, the outcomes of this by creating this patient-family engagement is really equity. It's really creating better outcomes and improved outcomes for this specific patient population that you have and really integrating that care. Lindsay is the one who taught me this. We wouldn't be where we are without Lindsay, Libby, of course, Lauren, and Mike. We really wouldn't be anywhere. And Donna, we wouldn't be where we are if we didn't have them. That collaborative that we did with them the first 6 months of our journey really got us exactly on such a good foundation and such a good place. Otherwise, we wouldn't know what to do. There really isn't a ton of information out there, except maybe other organizations that just have a handbook. So they really taught us about all these things, which are so great. Lindsay talks about how the funfetti approach is just like baking a layered cake. How are they baked into your organization? They should be layered at every single part. So they're really a part of everything that you do. And I love that it's the funfetti approach. It ends up being such a cute way to say it, but it really is true. They should be every meeting you have in your organization, they come up. For us, I'm always with my hands raised. I think that'd be a great thing for us to run by the patient family advisors. What do you think about us connecting and talking about that? So it's exciting to really get them into every part of the organization. The clear thing that this is really about is engaging diverse populations in inclusive activities to close the gap on disparities. So it's not just patient family engagement, but it's really for equity. I would say the word that I use more than anything else is co-design. It's my number one word for anything. Libby really taught me it's not a partnership. It's not. They're teaching you. They're not learning from you. You're learning from them, and really learning that perspective and creating a safe space where not just the patients feel safe talking, but that our staff feel safe too. Because I don't know if you've encountered this, but our staff really are concerned about HIPAA. They're like, can we really talk about that? Do we really want to air our dirty laundry? Isn't that going to make us look bad? But in the heart of quality improvement, we need to do that to get better.
Who does the?
Oh, sorry. So co-design is really the way that we do this. We do everything with them from the foundation, from the idea. It's really, again, not about us showing them, hey, this is what we're working on. What do you think about it? It's too late at that point. Not that that doesn't have value, but we really want them leading us. It's about creating those community conversations, focus groups. We have our groups working on things like social work may want to do community outreach on something. Well, what's the best way to get a hold of a community? How do you really get the word out there? Is it flyers? What do you do? Is it online? We know our portal doesn't have a lot of people on it. It's like 10%. So trying to find where it has the most traction, and like maybe there's 5 different ways you have to do it. But they teach us how to do that. So we have better outreach to create more resources for our patients, which is so exciting. And gosh, it's free. Like, I can't say that enough. These patients do this on their own. They do this because they want to give back and they love it. These focus groups are great. When we started telehealth, this was a novel concept for us. We talked about it for 10, 20 years, never did it. And then we did it in 3 days. And trying to figure out how do you really do telehealth? How do you do this? Well, having a patient family advisory council go in and do a focus group was brilliant. It was amazing. We knew there'd be a language barrier and that we'd need live interpretation, that we didn't have enough capacity to give that resource that was necessary. We knew that. What we didn't think about is, we have 2 of our patient family advisors have trachs, and they speak with their, ob traders and everything else. And so if somebody calls them on the phone and tries to do a phone visit for telehealth, that's not going to work for them. So how does our system know? Don't give them a phone visit. Quit giving them phone visits over and over again, because that's not going to work for them. They need a video visit, so working through those things, we wouldn't have that if our advisors didn't talk to us about these. Surveys are great. Storytelling, we're going to talk about a bit here too, which is just the greatest. This has always been one of my favorite quotes. When patient advisors and healthcare professionals are guided by mutual respect and a thirst to understand each other's perspective, priorities, and hopes, true collaboration begins. The gift is a profound sense of true engagement for positive change. And I just love that. I think that's exactly what it is. It's 2 people, a group of people coming together to want to make something even better, with passion behind it. And please just speak up if you have a question, because I don't keep all the pictures on at the same time. I get too distracted. That's my ER nurse background. I can distract easily. So what is a patient family advisory council? What is this really? Its purpose, we'll talk in a moment about it, but its purpose really and its value is really seeing everything from the community and the patient and the loved one's lens. I'm a patient. I'm a cancer survivor twice. I've had so many things happen in my life. Like, I feel like if people call me a cat, it's like I have 9 lives. I'm just so lucky that I'm even here, and to have people that have had these experiences and they come back and they want to give back and share is just remarkable. Because even though I've had those experiences, I didn't have them at county. I didn't have them in the same healthcare system as they did. And I don't have the same background. We all have different backgrounds. So it's just so special. I'm not the expert. My patients are. Quality and safety, of course, we use them on committees for each of these. Patient satisfaction is very important. We share our Press-Ganey, HCAPs, all of these things with them. And of course, we have a lot of community partners. We have different organizations that come through to our hospital to have meetings. And that's where I did some of our recruitment for patient family advisors, because it was just these are people who love your place and they want to learn more and they want to give more. So it was really a great place to recruit. So really the goal, and most of you might know this already, so I'm sorry if some of this just feels, very pedestrian for what you're used to, but just in case, it's really to address a multitude of healthcare areas, and it's through the lens of the patient, the guest, the community. Again, it's really through co-design. Right now, about 40% of health organizations have a PFAC, all different settings, and everybody focuses on something a little bit different. That was something that really was eye-opening for me, what people used patient family advisors for, all very valuable. We now just started using our patient family advisors in leading what research program projects we're taking on. And that's remarkable to me. They chose their top 3, and that's what we're working on now. And they're involved in all those plans. So it's just so exciting how, it's evolved over the years into something so embedded that they're now leading our research projects, in the direction of them for an academic setting. It's really cool. So this is really something that, again, Lindsay really taught me the best. Really some of the key things that Gateways puts you through is, how do you set the table in an organization? This is hard. This is really challenging. I didn't believe it was going to be as hard as it was. And this was probably the hardest part. I didn't realize that when I would choose specific patient family advisors for councils and to have them sit on those councils, that the staff would be different people when they're there. They didn't put them on the agenda. Oh my gosh, I was so embarrassed. They're on the council and they're not even on the agenda. There's not even a spot for them to talk. There's, even sitting in the first 2 meetings and talking with them before, I didn't understand it well enough to prepare them well enough. They just were clammed up. They were worried about what they'd say would be a HIPAA issue. And again, that dirty laundry, everybody is so scared to say anything bad about the organization, but that's kind of what we're here for with PFACs. We're here to make it better. I'm also going to talk about how to recruit patient family advisors. That was something that we used almost every method possible. And honestly, when we started a recruitment, it was a full 8 months prior to just the pandemic starting. So we went from having, I can go out to the courtyard, I can go to the farmer's market, I can go to the wellness center and huge events, to I can't do that ever again. And now I have to be really creative and figure out how to do this. I also have to figure out how to transition our meetings to online, which was not easy at first, knowing that a lot of our patients, this might be their first Zoom meeting. This might be their first time online, or raising their hand, or using a chat, or maybe they didn't have Wi-Fi. Trying to figure out how to do these things was really new for us. So I'm excited to share those. I think some of the hardest things are, how do you really have your first successful meeting? It's usually one patient and like 10 of you. So what does that look like? It's one person, and ours is Miss Vicki Jacobs. You'll see a picture of her in a minute, and her and I are so darn close. We're just like the closest friends now. But I remember that those first 3 meetings, that it was only her. And that's the only feedback we were getting. And that was okay. And I was so nervous because I was like, gosh, are we going to get anyone? But it worked out just fine. Once you get this really great family advisory council, which we have 11 members now, bilingual, we do all meetings in Spanish and English simultaneously with live interpretation. It's really figuring out how do you retain them? How do you ensure you don't have attrition? How do you ensure that they're satisfied, and also that your leadership partners are satisfied that are bringing projects to you? And then, of course, orientation, preparation, all those things. Those are all things to think about, that we got a lot of help from not only our volunteer department, but really also from Mike, Libby, and Lindsay. This slide, I'll do my best. I always cry when I get to this. This is 7 of our 11 patient family advisors, just the most beautiful people you've ever met. I have to remind you, they're volunteers. They're here just to give their input to make things better. Between there's 112 years of collective patient experience. It's remarkable. Up on the top right of my screen are Miss Arreta and Miss Mena, and they speak Spanish predominantly. So we always have interpreters with them. They are probably our 2 most active members on our whole council. Miss Vicki Jacobs is up on the top left and has helped us so much with alternative communication and what's really needed to provide equitable care. She can see through anything. It's remarkable. In the very middle on the bottom, Dimitri Lai. He came to our country. He was only here for 10 days and he got mugged and he got stabbed multiple times. They told him you'd never walk again. He's now on our Patient Family Advisory Council. He was my co-chair before, and he's in his 2nd semester of nursing school. So just the storytelling that we're going to talk about that's so powerful. It's what to hear them tell their stories. You can't help, as anyone who's in healthcare, or probably even not just in healthcare, to just get the chills and get so excited about, what these people bring. So again, it's really about that shared lived experience. What have they been through? What do they have to bring to the organization? When you have a meeting, even if it is maybe a retreat or something where it's a big exec meeting or med surg, it doesn't matter, but to have one of them come to those meetings and to start it off by telling a story, just 10 minutes, really sets the tone of your meeting. You go from burnout to this is why we're here. It changes the whole tone of anything you do by having a patient family advisor there. And again, they're free. They're your subject matter expert. You know, whether you're providing gift cards or lunch when they're there or a stipend or whatever it is, this really could be a consult. They are a consult service. You know, they provide focus groups. When we look at their things that they could be on membership for, so many things. They have been on so many councils with us. I really love them on our quality improvement council, but of course I'm a little jaded. They're also with me on the patient safety council. We have one on that. The entire council is also part of our hospital-wide patient experience council. So that's kind of fun too, because they're all on that, but they're on multiple councils. I keep a dashboard. I talked earlier about metrics, and this is a very small snippet of what it is, but I really look at how many do we have at that time, how many maybe interviewed, how many did we accept, you know, or maybe they interviewed, but they didn't end up actually starting with us. How many projects are we running right now at this time? How many total volunteer hours do we have? And that's from ad hoc projects, research projects, and our meetings. How many interviews are we doing, our attrition, our retention? And I keep up demographics. I'll show you that in a moment too. Something that's really important that Libby wanted me to talk about when I did the conference in New Mexico a few months ago for them was really, how are you ready? And this tool that they have for you through PFCC Partners, you could probably drop it in the chat, Lindsay, but this readiness tool is amazing. You know, it really goes through, it's just your step list, your checklist of, are you ready? You know, leadership buy-in is huge. The fact that the CQO and CEO asked me, there was already buy-in. So I was very lucky, and our CEO came from our sister hospital, Rancho Los Amigos, and he started it there 5 years before, and they were up to like 26 members, and theirs was huge, and they do all their wayfinding from wheelchairs. Amazing. So I had so much support for language services, everything I fought for. I had a voice, which was really nice. I had a seat at the table to say, if I'm going to do this, this is what I need for it to be equitable. I can't have live scan for these patients because what if they're undocumented? I'm not going to be able to represent our population if that barrier is there. So having that leadership buy-in is just remarkable. And Mike Renteria, who's I hope on this call, he was really our champion for that because he's over our entire hospital system. He's really the ones that can make that happen. So I'm just so grateful that we had such great leadership buy-in. Having foundational staff, gosh, I don't know how my boss knew exactly who to pick, but we had, you know, the director of volunteer services, we had people from the front line, we had people up that were a little bit higher in like medicine transitions of care. We had a nursing director, you know, quite a few different types of people. Facilities management was on it. And that foundation with the hospital administrators, like associate hospital administrators, that helped too. You know, having them on there, I don't have that brain. I'm a director, but I don't have that brain. I'm still a nurse at heart. You know, I do data every day, but that's not really what I do. So just having the right people at the table to start one is exciting for staff. And then really those all kind of go away and it's really just your patients and a few key members. That first charter that you develop is exciting and it's a working document, you know, and then eventually getting it to the point where they're running the show, not you. You know, you started off with a co-chair and then really they're the ones making the agenda. You debrief at the end, how'd it go? They make the next agenda. They decide what your annual goals are and your strategic plan for what you're going to work on. And you stick to that. And it's just really exciting because it's patient-led. You know, it's not something we're leading. So really the process is the same. The scale may change. We are such a huge med center. Again, 10,000 employees just on our one little campus. We have every service there is. And it's a public safety net hospital. So I know that we're in a different position than most people are, but it doesn't matter. If you have a rural hospital, it doesn't matter, whatever it is, you cast a wide net. You go out to, you know, your chamber of commerce, you go out to local community meetings, and that's where you recruit. You know, that's where you get these remarkable people that already want to be involved in the community. And after the pandemic, especially now that it's settled down, people want to give back. They want to help, but they don't know how to do that in a safe way. This is a safe way, which is exciting for them. I would say another thing just before I start on this slide is, you know, really your volunteer department. If you have a volunteer department, that is a great place to cast a net of putting it out to your director of, hey, if you think of anyone who might be great for this, send them over my way, you know, and really letting people know at your facility, this is what we're doing. If you know anyone with these kind of qualities, send them my way. I'd love to interview them. And here's an application. So really recruitment was very broad for us. We went on and on. This picture here is me and Mr. Argueta. We are at a hospital week last year. So this was last May for hospital week. And him and I recruit together. We're the dynamic duo always. I do outreach to staff and I teach them about our council. And he goes out to our patients and he tells them all about, and he tries to recruit patient family advisors, or at least to tell them, hey, this is what you have representing you, even if they're not interested in that. Staff referrals are amazing. Half of our people have come from staff referrals. But it's about educating them and letting them know who we are. So, we're in the process of an outreach campaign and it's hard. We have an Instagram account. We have a website that's public, that's private. But there's no traction. There is on social media, but not the other one. So really just trying over and over again, videos in the town halls, videos in these meetings, whatever we can do, we're trying. Posters, the application we have all over the place. Self-referral is another great way too. So we have applications in 6 key locations of our huge campus. They're in 3 different languages, our top 3 languages. They have a QR square so they can choose to do it electronically, and then it comes to me automatically on Microsoft Forms. Or they can actually just fill it out, and next to all those 6 boxes in key locations, they can put it into a secured locked box that we pick up every Monday. We pick up those applications. So by doing this, we really draw in a multiple generation and diverse community. We really work hard to get, and that baffled me. When Jorge asked me, he said, Les, I really want you, my most important thing for you to do is to ensure that you create a patient family advisory council that represents our community. And me, an ER nurse, I was like, homeless, incarcerated? What does this mean? I don't understand. How am I going to represent? And I wasn't even thinking out of the box. I was really thinking like my sole purpose in nursing are to do these things, but how do you get that population, and I really was thinking too close-minded. It's kind of like the, I don't know if you're even old enough to know this, but like, the Field of Dreams, like if you build it, they will come. That's kind of what it is. Like if you build it, they're going to come. They'll be there. Trust me. And I'll show you our demographics in a moment, just how blessed we are that they represent our community so well. So again, mindset's huge. Ensuring that our patient family advisors or patient family partners, as the PFCC says, is that input from the start. They deserve that. They deserve to help you be on that journey. Again, not at the end. They should really drive. They should be very embedded in the strategic plan. Ours have a whole bubble. If they fall under community, and there's 2 pillars under community, and the Patient Family Advisory Council is one of those pillars. So they are absolutely embedded and supported. And they went through our strategic plan and approved it and made some changes. So that's kind of a cool thing. They feel so empowered too. And again, those staff perceptions, it's a lot of education. Education. It's okay to talk about what we're not doing well with. That's why they're here. They're not here to just give us a pat on the back and say, you guys are amazing. That's not what they're here for, even though they do that constantly. So the structure of ours, our meetings are really, we do quality improvement projects all the time. We really keep in alignment with our strategic plan. We remind it often. I would say one of the things that has the most value by far that I've learned, probably my biggest pearl, is any meeting, any project we have ever done, I invite back that team, that leadership partner, whomever it was, 6 months later to say the status of the project of where it is now. Because it's one thing for them to work on it, but for them to say, okay, I did all this work on language and inclusion for 18 hospitals and I never heard about it again, or I made a video for the ICU for loved ones, but how did it work? Is it working? Are they still using it? Having them come back and tell them, we just want to thank you. We want to show you what this has done and where we've spread this to. That's so meaningful for our patient family advisors. And it gives all of us a sense of pride too. So I would say I probably get more excitement out of that than anything from the patient family advisors. They love that. Ensuring that they have the agenda a week before. It's in both languages, Spanish and English for us. Project slides, always Spanish and English, and it's always a week before, so they have time to kind of look through it and see if they have any questions. All the ad hoc committees can report at the end if they're on those councils. And then really thinking about what do you do when there's just one or two to start? You know, what little projects can you do when there's just one or two of them on it and a whole lot of you staring at them? I think that's a good starting point to think about too with your leadership. What do we really want to know up front that we could maybe use one or two people? Maybe it's a walk through an area to say, yeah, this would look a lot better like this, or this is really confusing in this waiting room of this pharmacy. If this sign was moved, it's so simple. It's amazing how cost effective our patient family advisors are. We're in there. Well, if we knock down this wall, if we, called OSHA and saw if we did all this stuff, and they're like, all you need to do is move that sign and the security guard's in the way, move him. And it's amazing because these are so simple. Their solutions are so brilliant and so simple. So really they save us money in so many ways. So really, here's one example of co-design. You want to reduce readmissions. So maybe you get a PFAC member to talk about their discharge experience. Identify the timing of the discharge instructions as an obstacle to understanding. They're like right walking out the door. They're not thinking about anything other than getting in their bed, getting in their shower, getting their warm jammies on, seeing their grandkids, seeing their loved ones, not being here with us anymore. They don't want that anymore. They're not thinking about discharge. So not only is it important to give it at the right time in the right language, but we don't want to spit out 50 pieces of paper on all these other things that have nothing to do with their actual discharge, and they're the ones who taught us that. You wrote this much, Mr. Arwetha, just a couple of weeks ago, this much is written about why I was here. The rest was on smoking. I don't even smoke. It's like, there was this part on mobility. I'm in great shape, so that feedback really makes us think like, yeah, we're wasting paper. This is so silly. Yeah, let's think about these. So really the PFAC works within an interdisciplinary team to then co-design that discharge process. How do you really improve those outcomes? How do you make it meaningful to patient and families? Because if you give any of us, even me, 50 papers after I leave surgery, I'm so overwhelmed, I'm probably not going to look at it for a while. And it would benefit me to look at it right away, but it's overwhelming. You're in pain. You've got too much going through your head. Maybe you were out of work for 2 weeks and you don't have sick time. These are things we have to think about and maybe they're the wet breadwinner of the family and no one else works. And now there's no income for 2 weeks. These are very viable scenarios for our patients. So, they're not thinking about this stuff right when they're leaving. So we have to start this stuff early, and be really meaningful in what we give them. So we use ours a lot in quality improvement. Telehealth was something I shared with you. We use them on redesign of areas. It doesn't matter if it's CLABSIs, CAUTIs, whether it's catheter associated urinary tract infections, fall rates, you name it. We like to get their input on everything from their hospitalizations or while they were there with a loved one. We have a few patient family advisors that were there as the grandparent or the guardian. And of course, patient safety. They really take a look at our campus and say, that's not safe. Or sometimes they'll text me and they'll say, I was walking through the parking lot and it's disgusting. There were gloves everywhere. There were masks everywhere. And when I walk through it every day, I don't see it as much as they do, but that's amazing for them to say, hey, I almost tripped on this thing. I'm like, gosh, thanks for calling me. I'm going to work on it right now. But I make sure I follow up with them and include them on the email chain. Just so this is what's happening now. It's fixed now, thanks to you. I thank them at the next meeting in front of everyone, so it kind of creates that safety of, yeah, we mean a lot here. We make things happen. So really, really involving them in the interview process is so great too. They give a different perspective than I do. I can really tell you a lot of things about what projects we do, but they can tell you what it means to be a patient family advisor and the time that they really have to give, using them for recruitment, like Mr. Arwetha here. I mean, we're together all the time. And he's Spanish speaking, and luckily I can speak with him the whole time. But it's just so nice. It's just so nice to have someone who's so willing to go out there and relates to our patient population so well. Our patient population, 65% of them speak predominantly Spanish. Really capitalizing on them for outreach, collaborating. If you have a public information office that does your as far as like doing your news and videos and all that, I would say just get involved with them in volunteer services and patient experience immediately. Those are really the best parts for us. And those applications, we have them in quite a few different places and they can come from a few different ways. So I think just casting that wide net, like Libby always says, is so important. this was some of the stuff that I looked at, when Jorge, our CEO, had asked me, I want you to ensure that they really meet our demographic. And again, that really boggled my mind to try to wrap my brain around what that meant. Two of my departments are psychiatry and inmate services. And so for me to wrap my brain around that as an ER nurse was like, how do I do that? But I was being too literal. This was a preliminary one that was done just a year ago. So there's much more of them now, but a couple of them just enjoy volunteer work, but most of them, it's really that they have gratitude for their care and they want to give back. It's about half and half. Half of them come referred from our own medical center and the other half are self-referral from on campus. So it's about half and half how we get our advisors and recruit. So again, involving that PIO, branding is important too. We got a logo, Instagram account, everything you think of, our vision statement, and just making sure it stays in alignment. We started to give each of our patient family advisors specific roles. So one of them is the social media manager. One of them is our website director, and one of them is the co-chair. And then they're all on other projects as well. So short videos work really well for staff. Just something really quick, just 2.5 minutes with the storytelling. And then really empowering those patient family advisors. One of the questions I ask on the survey is, how safe, how comfortable do you feel, giving your honest opinion at any meeting you're at, whether that's executives or with me, or whether you're on a council and I'm not there that day. How do you feel about that?
Leslie, real quick,
Sure.
can you redefine PIO, please?
Oh, of course, Public Information Office. Thank you. Yeah, so just your person, we barely got one. We had one before, but now we have a really robust one that really works on community involvement, everything you could think of now, but we didn't really have one before, not when we started this PFAC. So just some tips for meetings, always an agenda. At the beginning, I had to really make things timed because we would have very passionate discussions that would kind of blow out the rest of the topics. And so really learning how to navigate on the screen with that many people in 2 different languages and respecting everyone, but respecting the time for each person to present, that took a little minute. So I learned how to time things and I would give warnings like, this is such great information. We're going to go ahead and move on to the next section if that's okay. I send them text reminders. I have a group text with them that I do in Spanish and English the morning of. There's the agenda the week before with what we're talking about so they know what to expect. Always a map, even if it's all the same members. And we do hybrid. So we let them join online or come in person. So whatever works best for them, that's what we do. And definitely just having, those chair departments and department leads, if they're asking for us to have a representative, a patient family advisor, I ask that they come to the council meetings and present the information. They usually say, oh, you can tell them, you're on the council. I'm like, it's not the same thing. They hear me every minute. Like I don't want to be the one to talk. They're going to be so excited to hear you talk about it and why you would like them to be a part of your department, and represent the community. So getting the other members there are really exciting. One of my favorite QI terms in the whole world is nothing about me without me. And I think that's perfect for a PFAC, really figuring out what their passion projects are and trusting them is so important. This is Miss Anna here. She was my first co-chair. In May, she graduated with her speech therapy degree. And she won the biggest award for first generation cultural award. And she asked if I'd be her person to stole her with her gosh, what are they called? Her tassels, and say a speech about her. And so it's just remarkable how much these relationships build. It really is a family more than anything else. I almost want to put family instead of council at the end. Sometimes I cross it out as a joke and I put family instead, but they know I call them family all the time. So, using those stories, I don't know if anybody went, and we're right at the very end, but 2 weeks ago, I went to the Prescaney Human Experience Council, and I went to every single thing that was very similar to PFAC's patient engagement. It's just really what I'm passionate about. And really, Don Berwick says this really well. This was something from that. The value of storytelling in healthcare is immense and virtually untapped, which is so true. They are such a resource. If we don't preserve the richness of narrative, we'll fail to connect our patients' deepest experiences and our own. So, really support and resources. As you know, there's nothing better than the PFCC. They are really the backbone of where we're at. They are why we are where we are and how we built up what we have. We're so grateful for their step-by-step support. I'm sure they can tell you a little bit about the Gateways project if it's something that you qualify for, but it's also on the website. This was our very first visit with, you can see Libby Hoy right there in the middle next to me. And we're just so blessed. Lindsay has come on campus twice. She has done phone calls with us. We feel very supported. We feel so, I don't feel like there's anything I couldn't call them and be like, guys, this came up, what do I do? You know, so I'm so excited for all of you. I can't believe how many of you were on the call when I looked at the beginning, it was 52. And I can't see the chat right now, but I'm just really excited for all of you, and I'm happy to answer any questions at all that you have.
Thank you so much,
here.
Leslie. Thank you so much. This was so rich and so informative. If you all do have questions, please let us know. I see Aaron has one. Aaron, before you go, one quick one that came in with registration, Leslie, was, do you all compensate your patient family advisors?
It's such a good question. I would say that comes up more than anything. So because we belong to a whole healthcare system and we're a public safety net, we really do everything as a team. So we're kind of in limbo right now, waiting on what all of Department of Health Services wants to do. What we do is we provide a lunch voucher for them every single time they come, and they can use that whether that day, they can use it when they come to get labs the next time. It's always good. We usually have a few different, we have some like food there that is individually wrapped. So it's not something like, you know, when they started the research project, the research committee gave them Target gift cards for being a part of that council. So we don't, but we really try to work our way around it as best we can. Thank you for the question.
Thank you for that. Aaron Sturgeon?
Thank you. Yes. So I'm sure for a lot of the people on the call, but for us, COVID kind of slowed our recruitment and our momentum down a little bit. And a lot of our councils went on hold, and we've kind of been navigating how to revitalize that and also recruit members back again. So wondering if you have any suggestions or best practices to how to continue to engage PFACs during COVID, and then kind of what your recruitment onboarding process is. We have our volunteers fill out an application as well, but we always joke that we make it so hard for advisors to volunteer. So we're trying to make that an easier process for all too.
Those are such good questions. Yeah, COVID really did throw a wrench in it. I was like, we just got started. And then like, it was just like, oh, screeching halt. We got Microsoft Teams. It was training them. It was really going through, I had one-to-ones with each of them. And it was just patience. It was just spending time with each of them online and saying, and that's how you do this. And we just kept trialing it. So I would set up fake meetings, and then they would be on with me, and I go, let's do a chat. Let's raise our hands. Let's put mute on. Let's try this. And Nancy Velasquez, just the cutest patient. She was always sideways. Like for the longest time, she was like this in every single meeting. And we just left her like that. I was like, you know what? It'd be weird to see you straight up now at this point. I just want you to leave it, you know. As far as recruitment, certainly staff referrals are amazing. They really know who's engaged and wants to be a part of our community. So I would say that's huge. Having a platform that's hybrid really is mind-blowing, because then we have these ones who can be online, and there's a huge screen in the conference room we're in, and then we're all in person too. And sometimes I join online too. It just depends on where I'm at. It's really neat. That has really helped us a lot too. Recruitment, now that we don't have, we're still wearing masks, of course, and, you know, but we're able to be on campus now. So farmers markets, town hall meetings, anything you have, I would say if you have a med surg meeting, if you have an ambulatory care council, whatever it is, ask if you can show up, whatever it is. And that's kind of the thing. Like I hustle, wherever I can, I just show up. It doesn't matter what project we're talking about. I'm like, I am so sorry. How about we talk? You want to talk about, getting them involved, or, hey, you're the director of primary care. You must see so many patients on a regular basis. Do you see any that have kind of these qualities? It goes a long way for us. Is there any other part that I didn't answer about that, Erin? I don't know if I left something out.
No, thank you so much.
Yeah, the onboarding part, I'm always happy to share. On our website, I have everything that we've ever done. It's all based on Libby, Lindsay, and Mike. So I'm always happy to share anything. There's nothing that I wouldn't just give you that we've made that you can just edit to what you want.
One follow-up question, Leslie, from that. How often do your PFACs meet, and what time of day is that?
So we do a survey every year to see what the best time is. We use Outlook scheduling poll, or we'll use Doodle poll. We figure out the best time. Consequently, 4 years straight, we've had the exact same time. It's never changed. So we've been Thursdays, 11 to 12:30. We used to be 11 to 1, which was 2 hours once a month. Now we're at 1.5 hours on campus, but hybrid.
Thank you for that. I see, help me if I mispronounce your name. I apologize up front. Is it Janaya?
Hi, it's Janaea.
Christina. Thank you.
So I am new into the role as a family centered care coordinator here at a children's hospital. And the person that was in the role before me, it's been over a year. So the PFAC meetings have not been happening. We have a family advisory council, and we also have a youth advisory council. So it's been a year since the members that were on the council were active and present. So my question is, how long do you allow PFAC members to be on the council? Like, is there a term that they have to do? Is it 1 year, 2 years? Just because we're having our first meeting next week. So I'm just trying to gauge, how I should start the process with them again. Do they all start over? I mean, I'm obviously going to ask them what their interest is, but I just wanted to know, is it a time frame?
So I would say that's really personal, and it's a really good question. Most places I talk to have a 2-year or 1-year commitment. We don't leave a commitment at all. You stay as long as you want to be here, and even if someone needs to leave, we've had ones that have said, I'm going to join the Historical Society as a president. I can't do both of these. I'm like, well, listen, open arms. I'm proud of you. I'm excited. Congrats. Open arms. Like, anytime you're ready to come back, you just let me know, even if it's one meeting. You're welcome back anytime to the family. So we don't do, on our charter, we don't have a time frame. For the chairperson, it's supposed to be 2 years. But that's the only time frame we have. There really isn't a time frame for anything else on ours, but that's not how everyone does it. You can do it either way.
Thank you.
And congratulations on your new position.
Thank you.
I saw a question or a hand raised from Christina Campos.
Yes. Hi, can you hear me?
Yes.
Okay. Thank you so much for all this helpful information. I am new to this role as well as a patient family advisor volunteer manager. And I did have my first virtual meeting with the PFAC members the end of January. Unfortunately, I didn't feel like a connection with them because of the virtual meeting, and I just felt like it didn't go very well. I was asking to see if you have any recommendations on how I can build that relationship with them. The previous manager was in this role for over 10 years, so I know they had a really strong relationship with her. So me, new coming in, how can do you have any suggestions on what I could do to build that relationship with them?
Yeah, I would say storytelling. I would create a space where, you can say, I'm new to this. I'm so excited to be here. I'd really love to learn a little bit more about you all at a personal level, and maybe give them 2 questions that you want them to answer in a time limit. Maybe ask them what was it that made you join, and what do you love about being a patient family partner? And just have them say these things, and maybe that would give you that great connection with them. And they're here to tell their story. So that would be my suggestion.
Okay, thank you so much.
Sure. Yeah. And every time we have a new member, we have that one person do their storytelling on our agenda. And again, that came from PFCC. That wasn't us. They taught us to do that. And it really works well because then everyone gets to know them, and it just creates that human bond that's so necessary. And like you said, exactly, especially if you are virtual, and if people will put their video on, it's priceless, but it really doesn't mean as much if they don't. So luckily ours mostly have their video on the whole time, and that helps.
All right, thank you so much.
Sure.
Nice. I have one other question from that came in with registrations, and I think we'll have time for one other question from the audience. So there were several different questions. I'm going to kind of wrap it together, dealing with how do you form a diverse PFAC in a demographically limited community? And I'm going to add on, so when you talked about the justice system, or those incarcerated, or those that are in the child welfare system or undocumented. So how do you, I'm lumping them all together, if you will, but how do you, what are your suggestions?
So I would say, I mean, it's truly, I think about that Field of Dreams reference. If you build it, they will come kind of a thing. What I feel is that as long as you're representing your patient population, that's what's important. So, you know, if you have one strong demographic more than anything else, I would say that's probably most of your demographic and what most is important to be there, versus trying to diversify it where, you know, you want to get like every different type of ethnic background. It maybe really represent the LGBTQIA committee, which is something that we feel really strongly about. And so we ensure that that community is there. I think casting a wide net is just the best thing possible. Communities, going around to different councils on your healthcare system, going out into the community and kind of checking to see, you know, what meetings are they having in the community? What's going on out there, you know, and we're having a little recruitment table there is so helpful. If you're trying to get a specific demographic, what our patient family advisors have said is, you know, like if you're trying to get more of a Latino population, which is our population primarily, you know, there's very specific markets that would be important to go to, you know, where you might have a good, you know, capture of people. And that was from one of our advisors.
Thank you for that. I didn't see any other hands, so I'm going to add one follow-up to that. What are your suggestions if staff or personnel don't reflect the community that is served? So looking at diversity, equity, inclusion, so you can have a diverse PFAC, but if the staff doesn't reflect, so how do you build that when staff aren't a part of the community that they serve?
I would look at why the staff don't represent the community. Yeah, I would say when you're putting together your PFAC, try to choose a very diverse, something really important that I say a lot in our quality improvement council and, or I'm sorry, our quality academy that we do is everyone should have a role model. Everyone should have someone that they can relate to in one way or another. So we shouldn't all look identical, you know? So I think I would kind of look at maybe recruiting other staff members that could be on there, especially people you can empower that maybe don't get that opportunity all the time. It seems to be the same people that are always asked to be on every council, you know, the ones that are consistent and, you know, but there's other people that it'd be great to empower them and lift them up for this opportunity, you know? So I would just implore you to go out and try to recruit a little bit to make it more diversified. And I saw there were a lot of questions in the chat, so I apologize if I didn't, you know, if I didn't get to any of those and stuff.
We were keeping an eye on.
Oh, okay, thank you.
So we're good. I think the one question that may not have been directly answered, but I believe you answered it based off of resources on your website is what questions do you ask on the applications?
Oh, yeah. Yeah, I'm happy to share that. We do a rubric. It's in Spanish and English in case we're doing, you know, if Ms. Mena or Mr. Argueta is doing an interview with me, they have one that's in Spanish that they can ask them as well. We have an interpreter available. But yeah, you're welcome to have our tool for that too. It's basically 25 points. And we just rank everything the same. We have a very specific rubric that we keep on file. So it's always equitable. It's never us just saying, I liked them. You know, it's really, do they have the time? Do they really believe in our vision? You know, is this someone who, you know, has volunteer work experience or really seemed passionate about this is what they want to do, but yeah, Lindsay knows I'm always happy to share anything, whatever I have, I will always send anything your way. So if any of that would help you, if I can help with that, I'm happy to.
Thank you so much, Leslie. It's amazing how fast time goes. We are at time. This has been recorded and it will be on our YouTube channel. So subscribe to that. If you've missed anything, if you came in late, or if you need to rehear something and grab those answers, it'll be there. Again, thank you, Leslie. The slides will be, Leslie has said that we can share her slides. So those will be coming out to you. And if there is nothing else, happy birthday to everyone who is celebrating in February. Thank you for sharing your space and time with us today. I hope you have a wonderful weekend.
And please feel free to email me. My email is on the slide. You're more than welcome to reach out to me anytime.
Can you drop that in the chat as well? Because
Absolutely.
I'm not sharing right at the moment. And
Yep.
Thank you.
Thank you. Have a great weekend.
Thank you, everyone.
Thank you, Leslie. Thanks, everybody.
You're so welcome. Thank you.
Leslie's email is leslmartinez@dhslacounty.gov. That's leslmartinez@dhs.lacounty.gov. All right, everyone, take care.
Thank you. Have a good weekend.